Welcome to Aortic Dissection Awareness Week. I'm David Liang. I'm from Stanford Medical Center and the Hoag Marfan program, and I will be talking to you about the medical management and the prevention and treatment of aortic dissection. I want to thank Dana Milowitz and Amy Yazbek for inviting me to participate in the session. So aortic dissections, as in any sort of problem, really require three things, which is identifying the problem, knowing what to do, and then probably most importantly, ask for help when you need it. And so in the case of aortic dissections, well, it's important to make the right diagnosis. We need to know about the size of the aorta. We also need to know what causes it, because that impacts how we treat the patients. Then as far as, then we need to choose the right therapy, what we need to do. In most cases, it's about controlling the blood pressure. And in terms of asking for help, well, it's really asking surgeons for help when we think the risk of dissection is high enough that it justifies the risk of surgery. So anyways, I think Diana's already talked quite a bit about this, and you can go back to her slide and get a much more erudite explanation of the genetic causes of aneurysms, but there's many causes now. There's 11 genes we're positive about and many more that we suspect are causes of aortic aneurysms. And knowing what these causes are is critically important because they certainly alter the natural history and our approaches to these aneurysms in terms of preventing aortic dissections. So key to the diagnosis, however, still remains imaging. So this is a 3D reconstruction from a CT scan of an aneurysmal aortic root. You can see enlargement here. It looks like a bulb at the bottom, looks like an onion bulb. And so this is obviously what we have to see carefully and measure appropriately, because that tells us when a patient needs to be treated. For most of you, though, the initial assessment will be by echocardiogram. And so this is a still frame of an echocardiogram, and this blue line is across the aortic root. Now, one of the things that I present this for is that appropriate diagnosis is very important. So like all things in life, you need to do things well. And so this is a measurement of the aortic root. We get 4.7 centimeters, but in fact, the aorta is 5.2. And so this is the exact same patient. And this tells us the difference between going out the extra effort to really get the proper measurements. And so a key to management of patients, medical management, is getting good diagnostic information. Some of you will have CT scans, and CT scans, like echoes, are subject to quality of study. So this is our typical CT scan. It's done with contrast. You see dye in the aorta, and there's a series of slices across the body going downwards through the body. Now, one of the challenges, though, is that the aorta is kind of oblique, right? The aortic root you see going off to the side here. And so our slices on the CT scan are like this. And so you can imagine a pipe. You really don't want to measure these oblique pipes in order to get a good sense of the size. And so it's important to measure right across it, in which case we can do that nowadays with computers and taking the slices and creating what we call an orthogonal view, where just sort of right across it, you can see the three bulges of the sinuses of Valsalva. In addition, we need to also do a good job of freezing the cardiac motion. So the heart's moving. The CT scan takes time to get an image. And so if you're not careful, you wind up with these blurred images. You see this double exposure here, and this can overmeasure the size of the aorta. So this is what we call a cardiac gated study. So quality imaging done properly and interpreted properly is critically important in part of the medical management of aortic aneurysms and preventing dissections. All right, so what do we do once we make a diagnosis of an aortic aneurysm and we know how big it is? So the key to medical management remains limiting the blood pressure rise. So these are the standard guidelines. This is off the Marfan Foundation website in terms of what the exercise recommendations are. They're pretty prescriptive in terms of saying no more than lifting 20 pounds, no more than 110 beats of heart rate, and preventing trauma acceleration. Basically, we're trying to prevent sort of pressure load on the aortic wall, which is what we should do when you have a weakened aorta. But this is probably a little too rigid and accounts for different aspects of life and such. So, but what are the basic principles? And we can come back to these as a guideline, but what the basic principles are about limiting pressure rise. So why do we talk about isometric exercise or weightlifting? So this is from a very old paper looking at what happens to blood pressure when you're lifting weights. And so you can see that normal resting blood pressure is normal. As you lift a little bit of weight, it goes up. And if you lift a lot of weight, it goes way up. So it's important not to do maximum weightlifting where you're straining. In particular, it's important to keep breathing. So this is with Valsalva, where you hold your breath when you're lifting. You can see dramatic rises in blood pressure when you do that, both at rest as well as with lifting. So the idea is, yes, we want you to be fit, but we want you also to be careful and not push yourself to the limits, because that's when you get really, really significant blood pressure rises. So one of the ways I approach this is to tell patients to, okay, well, pick a weight where you can lift the weight 20 times and you're not straining at the end, okay? And that probably gives you a sense of, okay, we're not lifting maximally, but we're probably providing enough exercise that is helping you with keeping properly toned and preventing other problems. And then shouldn't we just make you sit in a closet and eat white bread and keep your blood pressure very low? That'd be pretty boring. But fortunately, this is data from done with Marfan mice, which was published recently, which is a little surprising, but very encouraging. So on the left panel here, we have the size of the aorta in normal mice, and then mice which carry a Marfan gene. You can see the aorta is obviously bigger, okay, even at this young age, which is sort of the equivalent of a human sort of early adolescence. But then we're going to take two groups, one of them which we're going to make into couch potatoes, and the other we're going to put on a treadmill and have them do sort of moderate aerobic exercise, at least the mouse equivalent of it. And you can see that over a 5-month period, the aorta grows much more rapidly when the mouse is sedentary. And so you can see at the end of 9 months, the aorta is significantly bigger in those who are sedentary as opposed to those who are exercising at a moderate level. So this is actually quite encouraging and tells us, yes, indeed, it's good to exercise, not only for the rest of the body, but also for the aorta. But these are at moderate levels. Okay, so what else can we do besides sort of guidance in life? Well, one of the recommendations is beta blockers, and this has been present for greater than 20 years. And this was first reported by Shores and Dr. Pieritz in a group of patients with Marfan syndrome. And so we treated half the group with no medications, just an observation, and the other half with beta blockers. You can see from the slope of the lines, the aorta grew much slower in those who were treated with beta blockers. So beta blockers has sort of been the standard therapy in that time, and we feel very comfortable with it. So what exactly are beta blockers and why are they useful? So beta blockers block adrenaline, okay? And they're particularly useful because of that in dealing with exercise. So if you take a group of patients who are equally treated with, in terms of the resting blood pressure, if you exercise them, you can see that people who are on the beta blockers have a much less significant rise in blood pressure than people who are treated with other agents for high blood pressure. So since in life we continue to exercise and be active, beta blockers are particularly beneficial. And in fact, that's why they're useful even in people who have normal blood pressures at rest. Okay, and this has been, what about other agents? So I think many of you heard of drugs, a drug called losartan or angiotensin receptor blockers. And this was really brought on by a lot of interest in the mouse model of Marfan syndrome that suggested it benefit. And it's been studied in various different trials. And we found that it probably does have some value in Marfan syndrome. So this is the US Pediatric Heart Network study comparing a group treated with atenolol versus losartan. Unfortunately, losartan did not turn out to be the miracle drug that everybody hoped it would be, but it probably is a useful armamentarium in patients with Marfan syndrome. And that's one of the distinctions we have to be careful about, because people, and unfortunately, doctors as well as patients have extrapolated that to other conditions. And I think that's probably not appropriate. You can see here the outcomes of the US Pediatric Heart Network trial. On the left is something called a Z-score, which is sort of normalized size of the aorta. And you can see that does slow down the rate of growth of the aorta. Atenolol actually on trending slightly better. And then similarly, the actual absolute size of the aorta both grew about the same amount, whether you're taking atenolol, which is the red line, or losartan, the blue line. But it adds a bit armamentarium, but wasn't as overwhelming as we had wished. There's some data that suggests indeed that if a patient can't tolerate a beta blocker, then adding irbesartan, which is another angiotensin receptor blocker, is helpful. So this is the data in Lancet. This is a group of patients who unfortunately weren't very much on beta blockers. So you can see that, yeah, in that population, if you can't tolerate a beta blocker, adding irbesartan does help to the regimen. So unfortunately, despite our medical therapy and guidance, we still have issues with when to operate because the patient still grows. And so generally, when knowing the diagnosis now becomes critically important, because if you look at the guidelines from European Society of Cardiology and ACC, the underlying diagnosis, Marfan syndrome, Loeys-Dietz, becomes critically important in guidance. And this is where natural history data has shown us that in Marfan syndrome, we know that the risk is very low, below 5 centimeters, so we can wait. Loeys-Dietz, however, especially in women with TGFBR2 mutations, we see early dissection. So obviously these patients need much earlier operations. And then in other conditions like ACTA2 mutations, which involve the smooth muscle, again, we see a fair number of people with dissections below 5 centimeters. So we need to think about earlier operations in that population as well. And then other conditions where size of the aorta is less predictive, like SMAD3 and myosin light chain kinase, we can see that we can use age, where dissection is very, very unlikely before the age of 30 or 35. So we can use age as a guidance in this population. So again, myosin light chain kinase. But what happens once the aorta dissects? Well, this is an aortic dissection. You get a tear, blood flow, and it separates the aorta. Obviously, this is the time when we call for help and get a surgeon to help fix the aorta. But the medical management still continues even after that, because in many of our patients, the aorta remains dissected distal beyond the repair. And we know that with proper management, survival can be good after an aortic dissection, with 90% survival at 10 years out. But oftentimes, we require surgery. At 7 years out, half of them needed a second surgery. So medical management and surveillance is very important after a dissection. So this is an example of one of my patients who we followed for many, many years. And you can see there's a residual dissection and descending aorta. And we followed them very closely early on, because you see this very sort of rapid growth from 3.1 to 4 centimeters over the first year and a half. But we also know that, okay, if we're careful, we're good about blood pressure management, exercise management, that you know what, we can stabilize the aorta. And so at 10 years out, it's only grown another millimeter. And this is the plot of the size of the aorta for this patient. We do watch them because some of our patients continue to grow. In fact, most of them do. And then some grow very quickly. And so that's why the early surveillance is really important. But in this population, even more important that we be aggressive in managing their blood pressure, because that early first few months when the aorta is growing, well, the aorta is really quite fragile. You can imagine you take 3 layers of the aorta, you separate them, so you only wind up with 1 layer protecting the aorta that early phase. Now the body stiffens it up with fibrin and such over the next few months to protect it, but then that early phase, keeping their blood pressure really, really low, almost to the point where it's intolerable, is important in preventing that early growth. And this is where close monitoring is followed, and the lifelong follow-up is important. So in summary, I think the keys to the medical management, probably as in most things, is good diagnosis, good monitoring. But then after that, our goals really are about trying to minimize the stress on the aorta, which is primarily the blood pressure. And then finally, I think understanding the disease and knowing when to ask for help is critically important. Thank you very much.